So an esophagectomy is a surgery that we do most often for cancer, but we also occasionally do it for certain benign esophageal diseases like achalasia or complications after reflux surgery, but mostly for cancer. And it's a surgery that was pioneered here about 40 years ago and been done here over 3,000 times now. So it is a surgery that we have quite a bit of experience with. It's a surgery that we perform, it's called a transhiatal esophagectomy, and we perform it through 2 incisions, one in the neck and also one in the upper abdomen. And through those 2 incisions we free up the stomach. We take our hands from above and below to free up the esophagus, and then we take out the upper stomach and the esophagus to remove the cancer usually. And then we take the stomach and bring it all the way up through the chest to hook up back up to the esophagus up in the neck. So that's what an esophagectomy is. It is a big procedure, and it is one that we evaluate our patients carefully for to make sure that they can tolerate it and recover well from it. But that's what an esophagectomy is. When we evaluate patients to see if they're a candidate for an esophagectomy, we're looking at many different aspects. One thing is to look at the disease process. So if we're talking about cancer, esophageal cancer, we want to make sure it's a cancer that is resectable. When we talk about cancer, there's different approaches. So everything from surgery by itself, if it's a very localized superficial cancer, to chemotherapy and radiation by themselves if the patient isn't healthy enough to have surgery, if the cancer's invaded too deeply or metastasized somewhere else. And in the middle, we usually combine those treatments. So I'd say the majority of patients get chemotherapy and radiation, and if their studies look good after that, meaning their CT scan looks stable or improved, and if their barium swallow looks improved, then we proceed with surgery about 5 or 6 weeks later. But to evaluate those patients, one, we have to make sure that their cancer is resectable. So usually there's a number of tests we get during the initial evaluation. That includes a CT scan, a PET scan, an endoscopic ultrasound, a barium swallow. So all those tests would need to be done, and usually before or right after we see them, those tests would be done. If the tumor looks like it's amenable to surgery, then we evaluate the patient to see if they're functional enough to go through a big surgery. Usually we ask them how far they can walk. We want our patients to be able to walk about 1 mile to 3 miles a day. And it's not all at once. I mean, these are guidelines just to help make sure that they're preparing for surgery. When we talk about these surgeries, it's like training for a marathon. You know, it's not just jumping right into surgery. It's something that we want them to prepare for, to be ready for recovering from a big surgery. There's also some testing that we can do depending on their medical history. So patients that have smoked or that have some shortness of breath will get pulmonary function testing. Patients that maybe have had heart disease in the past will get a stress test. So there's other tests that will help guide us to determine if the patient's a candidate for surgery. And finally, we're here to provide guidance and advice, answer questions, but in the end, the patient is the one to decide. You know, and there are many different options, and that's what we're here for, is to provide advice and information. When we talk about an esophagectomy and how it's performed, we have a wide range of techniques that we utilize and expertise that we have at our center. You know, this is something that we've done over 3,000 times now, generally for esophageal cancer, but also for benign disease occasionally. But when we look at the approaches, the first approach that was pioneered here about 40 years ago is an open approach. And this is an approach that was pioneering at that time because we try to avoid a thoracotomy or an incision in the right chest. And the reason is it decreases the risk of pulmonary complications or pneumonia, and the pain is less when you do it that way. So this is usually performed through an incision in the abdomen, upper abdomen, and also one in the neck on the left side. And through those 2 incisions we free up the stomach. And once the stomach is freed up, we free up the esophagus with our hands from above and below, and then we bring the stomach up to reconnect to the esophagus. But there are also some newer approaches that we're using, and I think the nice thing is that we perform all these approaches and we work with the patient to decide which one is the best for them based on their preferences and also their disease process, and whether they've gotten radiation, whether they've had surgery before. But some of these newer approaches are minimally invasive approaches, and so we're using cameras, laparoscopy, we're using robots and doing robotic surgery. But we're combining these, and I think the key for us is we have so much experience with treating esophageal cancer that we look at the patient and their disease process to decide which one is the best approach. But all these are available, and these are things that we would talk to the patient during their clinic visit about.